to look at your book while we're doing it. The test position is supine. So, in the clinic, please throw me a pillow.
Hey, no.
You're going to put a pillowcase on there for you, Julie. All right. Most likely you'll have a pillow under your patient's head when you have them lay down, right? Okay. The first thing that you want to do when you put your patient in a position for their range of motion is make sure that you're going to be able to get through the full range of motion, that there's no barriers. So you wouldn't want the patient with their head down on the side where there's a wall on this end, because if she tries to do shoulder flexion, she's going to run into the wall, okay? The other thing she can run into is the pillow. So whenever you're getting ready to do this movement, you want to slide the pillow over, so it's still under her head, see that? But we can go all the way to the table, okay? So you need to do that before you do range. I've seen students do this, and then they get up here, and they get here, and they measure, and I say, what was your end feel? And they say soft, and it's like, yeah, it was, because you're on a pillow. Okay, so we're going to slide it over. All right, so my origin, I'm sorry, I'm on lecture mode. My axis is what? I mean, just generally. The axis is the shoulder. Okay, that's what I'm looking for. The axis is the shoulder joint. So the reference that we use to be the axis through the shoulder joint is 2.5 centimeters inferior to the acromion. All right? Do you remember how to find the acromion? You follow the clavicle out. Okay? The clavicle comes together with the acromion at the AC joint. So you might feel a little bit of a ridge there, but you're going to keep going out. You're going to follow that out onto the acromion. And the acromion has a tiny little shelf that drops down just a smidge. You can usually get your finger in there a little bit, and then you've got the humeral head there. Well, it's the greater tubercle, really. Because the head's inside. My hand's cold. Yeah. Cold hands, cold heart. Right?
Makes sense.
Okay, so, did you say makes sense? I'm actually a really nice person. Okay, so you've got the following the clavicle. If you're lost, if you can't tell, because on her it's actually kind of hard to tell if I'm on the acromion or on the greater tubercle. But I can also follow the spine of the scapula, and I can find out where those meet. So I can follow the clavicle, and I can follow the spine around, and they're going to come together right on the acromion. So that's a better way, and I actually feel like I'm right on it, okay? Because my finger sits right down in there. Can you see kind of like a little bit of a dip? You guys can come up on this side if you want to see what's going on over here. There's all this. No. You are going to be on YouTube, just so you know. All right, so we're going 2.5 centimeters inferior to that. So that's going to be about this much, okay? If you're not sure, you have centimeters on your goniometer. One side is inches, one side is centimeters, okay? So we can find that acromion, go 2.5 centimeters, so right there. So that line, that point is supposed to be the point that pretty much goes right through the shoulder into the middle of the glenoid fossa. That's what that's supposed to do, okay? Now, I want you to just see what happens to this point, this lovely landmark, as you go into shoulder flexion. What happened to it?
Dips in.
How am I going to line my goniometer up with that? It's hidden, right? So you have to be able to visualize where that point was and keep your goniometer lined up at that point. So let's just do that. So we're going to go, here's our point right here, okay? 2.5 centimeters inferior to the acromion. Our stationary arm is midline of the trunk. So you have kind of this imaginary line that bisects the midline of the trunk, and it usually runs fairly parallel with the table, unless they're on like a saggy bed or something. Okay? And that could be, if you were doing home health, it's possible. And then your movable arm lines up with what?
Longitudinal axis of the humerus.
Longitudinal axis of the humerus, using what as your landmark? Is that all it says? Oh,
It just says parallel longitudinal axis.
well, that's it. We used to use. Oh, okay. So there is no distal landmark. All right. The other thing about shoulder flexion, you cannot achieve full shoulder flexion with the palm up or the palm down. So try to do that just standing. Palm up, try to go as high as you can. What do you feel? Can you go all the way up? Okay. Palm down. Be careful with this one. How high can you go? Humeral head cannot clear the acromion with internal rotation or external rotation, so you've got to be neutral. So we do it thumb up. Okay, you always do shoulder, abduction, and flexion with the thumb leading the way. All right? So if we want to go midline of the humerus, we basically have to draw an imaginary line where the humeral shaft is. Okay? And if the thumb's pointed up, we can use the lateral condyle to help guide us, because that's going to taper in to the shaft of the humerus. Okay, so here's my fulcrum, stationary arm, and my movable arm. And I'm going to have you bring your arm straight up overhead as far as you can go. I'm going to follow that. Now notice that landmark on the skin has disappeared, but I'm going to stay right there in the same place where I'm still going right in the middle of the glenoid fossa, pretty much, the imaginary line, okay? I'm not up here. That's going to be distal to the deltoid, really. I'm not going to be down here on the scapula. I got to stay right here over the ball part of that ball and socket, okay? So she actually has 180 degrees. Now, there is a substitution occurring right now. See if you guys can catch it. She's arching her back, so I need to fix that, right? And so let's see how far she can go without arching her back. That's it. She starts to arch her back from there to there, okay? So we'll just measure it to there. So let's keep your back from arching, and we're going to measure her to right here. Notice I'm kind of stabilizing here. And she's only got, where you kind of thought she had full range of motion, she's got 165 degrees. What's normal? 180. Now, what if you have someone that has a lot of mobility, and you're trying to identify if they have a lot of hypermobility? Then I could slide her down towards me, and I could see, she's not going to because she actually is limited, how much further she would go. This is all compensatory though. Okay. Some patients, their back is completely flat and the arm just goes, you know. Okay? So that would be flexion. I'm going to have you, well, let's look at how you would do passive. Okay? Passively, I'm going to grab her arm and the goniometer, but I'm going to grab below or at the elbow so I can support what's going on here. I don't want to grab, here and just let this occur. That doesn't feel very good, does it? Okay. So I'm going to line my goniometer up again, grab her arm, okay, and I can bring her, just relax, completely relax your arm. I can bring her up. Now what I'm going to have to do here is switch hands, okay, so I can control what's going on. But I need to stay here. I don't want to be up here because I'm not going to be able to read the goniometer very well. Although you'll see some therapists kind of do that. Let's see. arm and come up where they have a little more leverage because they're above. Okay. Notice also that you can be affected by the table pushing up on the goniometer. If that's a problem, just have your patient scoot out so that now the goniometer can be right where you want it. You don't want to let the table determine that you're going to move the goniometer up. You want to keep it right over that axis point. Okay? So let's go ahead and do extension because they kind of go together.